So my title today is Feasibility, Safety, and Efficacy of Iron Bioresorbable Stent Scaffold in neonates with a duct-dependent pulmonary circulation. So this is my disclosure slide. I have to declare that this research supported by LifeTech Scientific, and this paper has already been published in Annals of Paediatric Cardiology 2022. It was, I think, April version. All right, so this topic will be divided into 3 parts. The first part is the elaboration of duct-dependent pulmonary circulation, challenges of a bare metal stent in congenital heart disease, and also the demand of bioabsorbable stents in human. And the part 2 is basically the history of bioabsorbable stents and also the new IBS stent profile. And the part 3 is our experience in IBS implantation in duct-dependent congenital heart disease, and also initial and final results, and also conclusion. So I'm not sure how many of you familiar with a congenital heart disease. So let me elaborate a little bit more. So this is a complex congenital heart disease, what we call pulmonary atresia. So this example, this is one of the patient. Usually they are born with a hypoplastic right ventricle and also atretic pulmonary valve. So this group of patients require ductus to provide the pulmonary circulation for only transient, and require further palliation like PDA stenting or BT shunt to provide the palliation for pulmonary circulation. So in this PDA stenting, there are 2 types of indication. The first one is basically the stents that provide the additional source of pulmonary blood flow into the pulmonary circulation. Example, patient with a PIVS or pulmonary atresia with intact ventricular septum, or critical pulmonary stenosis with small RV cavity, which is this RV cannot provide enough flow into the pulmonary circulation. And the PDA morphology in this group of patients usually stent friendly. They originating from the descending aorta and relatively very straight, like this patient. And there's no branch PA stenosis. The second indication is those with more complex congenital heart disease, like TOF pulmonary atresia, or more complex pulmonary atresia, like TGA VSD pulmonary atresia, or CCTGA VSD pulmonary atresia. And some of this group of patients also has single ventricle physiology, which require the PDA stent as initial palliation. And PDA in this group of patients, usually they are coming from the underneath of the aortic arch and tend to be very tortuous and insert into either branch of pulmonary artery, either right or left, and causing pulmonary artery stenosis. So the issue with PDA stent in this group of patients, usually technical and vascular access, complication, the fate of the stenosed branch pulmonary artery, and also impact of the surgical repair later on. So how important is this bioabsorbable stent? So we are basically looking at patients who are considered as a straightforward PDA, as the pilot group. So because we know that this group of patients usually require PDA stent for only about 6 months earliest, or maybe 9 months or 1 year. So yes, we do have patients with more complex morphology of PDA, but the initial study is basically focused only on the simple ductal morphology. All right, so what are the limitations of the current bare metal stents? So we know that this group of patients usually require multiple surgery. And from the previous publication, we also noticed that it's a bit difficult for the surgeons to remove the stents during the surgery. So what the surgeons usually do, they leave partly of the stents and remove partly, and this may later on cause either branch PA stenosis. So example in this group of patient where you can see the flow into both branch pulmonary artery and a bit of the stent material in the pulmonary artery. So this is another limitations of the bare metal stents, which require a lot of re-intervention, like causing LPA, RPA stenosis, and furthermore require LPA balloon dilatation or branch pulmonary artery stenting in the future. So this is basically give us an idea of having this bioabsorbable stent as an option, basically to for the initial palliation. So the importance of this bioabsorbable stent is basically when they are absorbed, the surgeon has a better surgical outcome, and also with the patients requiring pulmonary artery reconstruction, and the surgeon has so-called much easier work to do. So there are a few reported or published papers on bioabsorbable stent in the past. However, this is not carried forward because of multiple problems, like problem with the scaffold or instability of the stent itself. So the idea of this bioabsorbable stent is coming from the derived from the adult study. The adult study used sirolimus eluting iron bioresorbable stent for the coronary stenting. However, for the neonatal stenting, we remove the sirolimus, the drug, and we leave the iron as a scaffold. So this is the IBS profile for study in the adult patient with coronary heart disease. And more important that I want to highlight is basically the stent strap. It's only 70 micrometer, and the degradation period of about 12 to 24 months. And as compared to the previous bioresorbable stent, which is no longer in the market, example, this absorbed by Abbott, the degradation period about 36 months, and McMurray stents by Biotronic, this I think the degradation period of about 12 months. So this is the brief development of this IBS stent, where it was developed way back in 2006, when the first idea of having this iron scaffold stent, and also the study was carried on until it was implanted in animals, more than 600 pigs and also 3,000 rabbits. And more than 10 years of this study development, we can see that this is probably a good and better outcome for us to move forward for the implantations in human. So this is a result of the animal study, where they can see at the 28 days, the stent was still patent up to 19 days. Then they start corrections about 180 days, and later on become more absorbed. This is the image from the micro CT. And by 13 months, you can see that almost all, maybe left only about 10% of the stent material. So in vivo resorption, so the iron consists of about 80% of the scaffold. Hence, this iron, when they are absorbed, they transferred in to hemosiderin in adventitia by macrophages, and excreted to the lymphatic system and also spleen. This is, I think, the normal iron metabolism in our body. So for this IBS study in duct-dependent pulmonary circulation, so this is a pilot, there's no drug, we remove the sirolimus, and the main purpose basically to study the feasibility, safety, and effectiveness of this IBS stent in PDA with simple morphology, like pulmonary atresia, intact ventricular septum, or critical pulmonary artery stenosis. Sorry, critical valve stenosis. And also to provide the basis of maybe larger scale of study in the future for more complex PDA, and also to see how easy to handle the stent, visibility on the chest X-ray, the acute result, and also post-procedure ICU result. We also study the post-discharge performance of the stent, the patency of the stent, the serum iron content, and also the outcome of up to 9 months, or the endpoints, either death before 9 months of the post-procedure, or if the patient require restenting or early surgical procedure. So this is our methods. All patients less than 3 months old, more than 2.5 kilogram are included. And the screening tool, usually our echocardiography, and this patient was brought to invasive catheter laboratory for angiography and PDA stenting, plus balloon valvotomy. And this patient will be monitored at 1 month, the clinical chest X-ray and echocardiography, 3 months clinical examination, also iron study, chest X-ray and echocardiography, 6 months the clinical iron study, chest X-ray, basically we change to fluoroscopy, and 9 months as a final endpoints. So this is the follow-up schedule for all these patients. And all patients require either aspirin or clopidogrel, depending on the disease PD status. Some of these patients require both aspirin and clopidogrel. So this is just example one of the patient who had a hypoplastic right ventricle, dilated right atrium, and good function of the left ventricle. And the pressure gradient across the tricuspid valve because of high right ventricular pressure in this patient is 150 millimeter mercury. So this is the pulmonary atresia. There's no flow into the pulmonary circulation, and the procedure is followed by balloon dilatation, perforation of the valve, and balloon dilatations of the valve. And this is the PDA, which is very small in this patient. This is the PDA. This is lateral view of the iotogram. Again, this is the ampulla. This is the AP view. This is the coronary guide wire, which was advanced into the pulmonary artery across from the aorta, PDA, into the pulmonary artery, and parked in the right pulmonary artery distally. So later on, when the wire in good condition, then we advance the stents. This is the 2 marker of the stent, and the stent was then inflated. Sorry, I go backward. Okay, sorry, the stent is inflated. Okay, a few more seconds. Yes, the stent is inflated, and the final angiogram showed very good stent flow into the pulmonary artery. So this is the stent visibility on the fluoroscopy, and the echocardiography. You can see very patterned flow from the aorta into the pulmonary artery. And this is the visibility of the stent on the fluoroscopy at 1 month period. So this is 3 months follow-up. You can see the stent flow is reduced in this case, and the visibility of the stent, if you see on the fluoro, is much less at 3 months period. So this is a total of 9 patients that we did, and the summary of the findings in the acute to medium term, or in all 9 patients, all procedure was successful. There were no major complications. Example like stent migration, cardiac tamponade, or acute stent thrombosis. And the ease of implantation is similar to the bare metal stent. And the chest X-ray visibility on the fluoroscopy, you can see as compared to the bare metal stent, is about 50% of the standard bare metal stent. But still, this is visible, especially when there is 2 markers on the stent. In the initial period, there's a bit prolong of pulmonary over-circulations. It's also due to the stent size. And all patients were discharged well and or either transferred back to the referring hospital. We have 1 mortality, but this patient was discharged well, came back with RSV infection and severe lung disease due to RSV. So in total of 9 patients, 1 patient died, and 4 patients has restrictive stent flow at 6 months, and 4 patients had good stent flow beyond 6-month period. But in these 3 patients, 1 patient had surgical corrective surgery, and 2 more patients require no surgical correction because this patient has attained good 2-ventricle physiology. In one of these patients who had tricuspid atresia, require restenting at 4 months due to reduced blood flow into the pulmonary circulation. And out of 4 patients in the patency more than 6 months, 1 patient, this patient has a severe pulmonary vein stenosis who was managed conservatively, but the stent flow was still good. And 3 patients had RV overhaul surgery or RVOT reconstructive surgery. So this is one of the patients who require unanticipated surgery. This is a follow-up at 6 months post-procedure. You can see a very tense right ventricle, hypertrophy right ventricle, and a bit of pericardial effusions there. And what we notice is basically limited flow across the pulmonary valve into the pulmonary circulation. So this patient had open heart surgery, which require implantations of the monocarp's valve and removal of the stents. So this stent, once we have removed, and this stent was sent for the micro-CT examination and also histopathologic examination. So this patient is post-op, immediate post-operative. The RV contractions is better, and the functional, this is the functional monocarp's valve was implanted. So as a result of the micro-CT scan and also histopathologic examination, from the period of 6 months to 16 months, you can see that the stent loss is about 10% and 2/3 by 16 months. And you notice that a few inflammatory cells at the initial period, but of course, by the time goes by, then you see the disappearance of these inflammatory cells, and the stent is then absorbed into the circulation. So, of course, the limitation of this study is basically this is a small non-randomized prospective pilot study in our center. And although the PDA morphology was probably relatively straight type, but the pathology of this patient is quite varies. And we know that some of these patients may destined for biventricular pathway, and some of these patients may require univentricular pathway in the future, or at least 1.5 ventricle. So as a conclusion, ladies and gentlemen, the acute and early post-procedure result of this IBS bioresorbable stent as an initial palliation in congenital heart disease with duct-dependent pulmonary circulation is very promising. And of course, this is a pilot study, is limited to the sample size and also the pathology of the patient. And we notice the ease of implant similar to the bare metal stent, and also the chest X-ray visibility is about 50% of the standard bare metal stent. And by 6 months, most of patient has inadequate stent flow. But again, the duration is sufficient for us to proceed with either definitive surgical correction, or the RV cavity has improved and does not require any more surgical intervention. Second conclusion is basically this stent is feasible and very safe to be implanted in selected patient. And of course, there's early luminal loss, and we would recommend for the close follow-up for this group of patient. And furthermore, we require larger multi-center study for more conclusive recommendation. And bioabsorbable stent in PDA is probably something good that when we can apply in more complex PDA with pulmonary artery stenosis, which require pulmonary artery reconstruction at the later stage of the surgical repair. And of course, this objective require more clinical study. And I believe the development of the stent itself should be refined, especially the design, and may also incorporate some anti-proliferative drug to the scaffold for the wider use of IBS stents. So with that, I thank you all for your attention.
Thank you, Doctor, for that presentation. It was a very beautiful and a very excellent one.